Good afternoon. Good afternoon. My name is Ann Roy, and I would like to welcome you all on behalf of Medicare for All Easthampton Hub and Medicare for All Western Massachusetts. Not good. Our ultimate goal is to get a single-payer bill. Our near-term goal is to get you out to vote for question 4, and you will hear more about that in a moment. The film today is brief but powerful. It clearly depicts the failure of our current healthcare system. It highlights the liabilities of a healthcare system driven by, I have to say it, driven by greed and insurance. Okay, so after the film, we'll have a Q&A with Dr. Gerald Friedman, who will be here momentarily, I believe. Is that correct, Sarah? All right. Now, a few words of hope. Number 1, we hope you enjoy yourself today with popcorn, camaraderie, and apple cider. We hope you leave inspired. We most certainly hope you vote yes on question 4, but most importantly, we hope you go forth and spread the word of single payer. Thank you.
I saw it. My name is Claire. I'm a member of the Easthampton Hub, of Medicare for All. Before I introduce our speaker, I'd like to remind people, if you're interested in taking action, we have some suggestions on the pink sheets in the back. If you didn't get a chance to sign in, please do so we can keep you informed on how things are going and how you can possibly help. And I do want to remind us all about the timing. We do want to wrap it up by 5. We want to have some time for a few announcements at the end. And if you've been paying attention to the film, you're going to recognize our speaker, Dr. Gerald Friedman. He has many academic successes in Columbia and Harvard, the 4 books he's written on economics, his longtime position at UMass as a professor. What I would like to bring about is his tireless enthusiasm on this topic. He's been doing it for decades. He's been saying the same thing for many decades, as cheerfully the whole time. He really is an unbelievable force. He does bring economics down to a place where we can all understand it, which we all appreciate. And I did a little research on him, and I found that his students, the most common label they have for him are 2 words, respected and hilarious. Ladies and gentlemen, Dr. Friedman.
Thank you, Claire. That was very generous. They do say other things about me, actually. The most common, on the course evaluations, the most common thing is, because it's an 8 o'clock class of 700 students, it's economics, it's boring, it's too early in the morning, and Friedman just goes on, but he brings his dog to class. So it's all okay. My wife's walking the dog around Easthampton. She was threatening to go to some clay studio down, and so, but maybe he'll be here by the end. I don't know. Yeah. But yeah, Claire's right. I have been at this for a while. The first time I did a single payer event was in Washington, D.C. in 1979. I went down there with Michael Harrington. Some of you may know the name. It was to support Senator Ted Kennedy. You know that name, his single-payer bill. And I've kind of been at it since then. So the obvious question is, what are we doing wrong? Because it's like, how come we don't have single-payer yet? And it takes me a while, but I did figure that out a few years ago, because I'd been going around making estimates of how much money we would save from single pay. You heard some of them on the movie. And the numbers keep going up. They get bigger and bigger. And you talk to economists and policymakers, basically everybody agrees that single pay is the better way to go. A few months ago, you may have noticed this Koch brothers group at George Mason University, which, with all due respect, is basically a right-wing think tank propaganda place. And they did a study of single payer, the Bernie Sanders bill in the Senate, and they concluded that it would save $2 trillion over 10 years after giving universal coverage and eliminating copays and deductibles. So everybody would have better health care, the uninsured would be covered, and it would save $200 billion a year. And that is the right-wing economist assessment. So with all this, why don't we have it yet? And then a few years ago, I realized that every time you go around saying that you're going to save all this money, every dollar of savings is a dollar of somebody's income. And that's our problem. Now, some of it comes out of the income of people doing lousy jobs that they don't really want to be doing. The average turnover in billing and insurance activities at hospitals and the big insurance companies, the average turnover is about 5% a month. People in these jobs don't like the jobs very much. They're not very good jobs. So that's not the problem. The problem is the people at the top who are making huge amounts of money. The average pay for a CEO at one of the 10 largest health insurance companies in the United States is over $20 million. You go to the top hospitals. The only people in state governments throughout the country who are paid as much as football coaches and basketball coaches are the heads of the hospitals. A few years ago, I ran into a former student. I teach 1,500 students a year, so this happens. I have to be on good behavior when I'm crossing the street and things. I can't give anybody the finger if they're driving too fast and scare me, because that may be a student of mine. But anyway, I was at Bradley Airport, and this guy comes up to me. He says, "Oh, Professor Friedman." And it turns out, he was flying home, and I was flying someplace. And I talked to the guy. His father's a hospital CEO in Milwaukee. And the kid's very proud of his dad because he said, "My dad is the only hospital executive that he knows of who's paid less than $1 million. My dad's not one of those people who's just in it for the money or whatever, I didn't ask how much he was being paid, and I'm not saying that the head of Cooley Dickinson is not worth it, whatever. Well, I don't know. Yeah. But the point is, however, that you have a lot of people with a lot of money at stake here. The heads of the hospitals, the heads of the insurance companies, the heads of the drug companies. Oh my God, don't get me started on the big pharma. Big pharma is the biggest lobby in Washington. You may remember the military-industrial complex, Lockheed Martin and those. Oh, they're nothing. They're like number 5. The top lobbying groups in Washington are Big Pharma, number 1. The hospital associations, number 2. The health insurance companies, number 3. And then I think the lawyers are number 4. But, I'd have to check again. But Big Pharma is way up and top there. Okay, so these people, why are they spending all this money lobbying? I mean, all this money, $200 million last year, and that wasn't an election year. Big Pharma spent $200 million on lobbying in Washington. What? Yeah, but that's what we're up against, because what are they protecting? They're protecting billions, trillions of dollars in stock equity. The top pharmaceutical companies, as of September of last year, when I had an undergrad do this, so it's almost a year ago, they were worth over $2 trillion. The top 10 health insurance companies worth $500 billion. And all of the health insurance market value and much of Big Pharma's market value would go away with a rational healthcare system. Because how are they making this money? They're making this money by charging higher prices than the cost of the services that they're giving us. And they get away with this because, as the movie talks about, there's nobody on the other side pushing back except Medicare. Medicare doesn't put up with this bullshit. Medicare charges hospital prices. At this point, it's gotten so bad. The average cost of a hospital stay on private health insurance is 90% more than the cost if you're on Medicare for the same services. You go in for an MRI, you go in for x-rays, you go in for whatever it is, they're going to charge almost twice as much if it's private health insurance. They don't get away with it with Medicare. Medicare is such a big buyer that they can't do that. Medicare, if we, the standard saying, which is almost right, is that we pay twice as much for healthcare as the rest of the world. It's not quite. It's like 60% more. So, but if in 1971 we were paying about the same for healthcare as Canada, and our life expectancy was a little bit less than Canada's. Since then, our cost of healthcare has gone up to about 70% more than Canada. All of that increase is in the private health insurance sector. U.S. Medicare has controlled costs as effectively as has Canada's Medicare. That's what they call their single-payer system up there. They call it Medicare, and every time they say it, they giggle. The rationality is clear, but it's all the monopoly profits that are the problem. And the other thing is, it's gotten worse. It gets steadily worse over time. It's gotten worse over the last 40 years. And most of what we've done in this country has made it worse. Because, and here I confess my membership in an evil association. And that is the American Economic Association. Because it's the economists who are at fault. Back when I was in graduate school, I remember one day we had a seminar. I was doing anthropometric history, height by age research and demography. It's still embarrassing, but just about my most widely cited article is something I wrote on the demography of Trinidad slavery in 1982. And that's still, it's been downhill. But anyway, we had Richard Zeckhauser, who at that time was in between administrations. He had been in the Nixon White House, he'd been in the Carter White House, he was later to be in the Reagan White House, and then the Bush and Clinton. But at that time, he was head of the Kennedy School, and he was an economist. And he came in and he explained to us that the problem with healthcare in the United States is insurance, because people don't pay the cost of their healthcare, so they overuse the system. Grandma gets lonely, he said, and goes to the doctor to have somebody to talk to. The proof that this is wasteful is that all the gains in life expectancy have come because of clean water and public health and not because of what doctors do. Now, that's not true. It wasn't true then, and it's not true now. Evidence for it is if you look across counties in the United States, there are surveys of the proportion of people who report that they cannot afford to go to the doctor because of cost. Counties where people cannot go to the doctor have higher mortality, even controlling for things like health insurance, income, race, etc. When people can't go to the doctor, they do die. Zeckhauser was wrong. But think about the implications. Here we have one of the most important people in shaping healthcare policy, and he didn't believe that healthcare was important. He believed people overused healthcare because they weren't paying for it. The solution, get people to pay for it more. And that has been what we've been directing at. Co-pays, deductibles. 20 years ago, the annual survey done by the government of employer-provided healthcare plans didn't even ask about deductibles because they weren't important enough. But much of what we've been doing has been to tie your healthcare to how much you spend. Deductibles, co-pays, the fragmentation of the insurance market. Back when I was a kid, there was one insurance plan. We practically had a single-payer system, at least in New York State. It didn't cover everybody, but everybody who had health insurance was through Blue Cross Blue Shield. There was no other health care plan. It was a state-regulated monopoly, and that's the way it was in virtually every state. One private health care plan, but it was a not-for-profit, and it was regulated. They had to have community issue. They had to charge the same for everybody, regardless of health status, and they had to have universal access. They had to give you insurance at this rate, regardless of pre-existing conditions. That was America in 1971. The only thing is, it wasn't publicly financed and not everybody was in. There were many uninsured people. But that's the way it was. We've done away with that because we listened to the economists, and it's made the system more expensive and less equitable, and it has made Americans less healthy. 200,000 people died last year in the United States because they could not afford to go to the doctor. A third of them did not have health insurance, but 2/3 had health insurance but still couldn't afford to go to the doctor. And that number is probably just going to soar in coming years as the Trump administration chips away at the Affordable Care Act. And if they win the next election next month, then they will repeal the Affordable Care Act. They'll have the votes in the Senate, and they'll have the votes in the House, and then things will get even worse for those without pre-existing conditions, with pre-existing conditions, and for everybody else. Okay, so why don't we have single payer? Because the political forces mobilized by big pharma, big insurance companies, and all those who have been benefiting by this market turn. We pay more in co-pays and deductibles, they get more in profit. It's as simple as that. Now, they've got a lot of money. They can pay a lot of economists and a lot of other people. All these economists I talk to who agree that single pay is the right way to go, they then very quickly turn around and say, oh, but it's not politically possible. Well, it's not going to be politically possible unless people get together and do something about it. They said we can't become independent from Britain. And the people of Massachusetts did something about that. They said you can't end slavery. Oh, you talk about a political and economic juggernaut, much, much bigger than even big pharma, the slave power. And people in Massachusetts did something about that. Yeah. Right now, we probably won't be able to do anything on the national level, but within Massachusetts, we could do something about health care right here, and we could do it, well, not right now, but maybe January, when the legislature reconvenes. The legislature in Massachusetts could pass, they could enact a single-payer program in Massachusetts. They could enact, it would save people in Massachusetts, about $20 billion now wasted in administrative waste and excessive prices of drugs and hospitals. They could enact a whole bunch of other measures. I've got a paper, 11 steps towards single payer, intermediate steps. I need to make that 12 because I figured out another good thing. Peter Kokot was going to be, but that didn't happen, so. Okay, anyway, I'm happy to take any questions, tell you about my dog, or anything else. There is a microphone.
We have a
for
microphone.
people.
I'd like to make sure you speak into it so everyone can hear.
You talk about getting Medicare for all in Massachusetts. So what's our governor's position on that since he's likely to be reelected?
Our governor, before he was elected governor, you may remember, was head of Harvard Community Health Plan. He was a health insurance executive. He was very well paid. Before that, he was a conservative politician. It would have to be enacted over his veto. I think that's pretty sure. On the other hand, Jay Gonzalez may yet win. Put it this way, he hasn't lost yet.
Yes.
Is there any state that has approved single payer in the country?
No.
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 So if we were to approve it, would we use the Medicare rules for Massachusetts?
Well, okay. A single-payer plan in Massachusetts would be partly funded through Medicare. Now, what we would do is, to get into the weeds a little bit, would establish a Medicare Part C plan, a Medicare Advantage plan, that would be integrated with the state Medicare for All plan, or universal coverage plan. Try not to use the same word too many times. And everybody on Medicare would have the option of joining the state plan. The federal monies would flow into, that would have gone for the Medicare would flow into the state coffers. And if they join the state plan, then there would be no premiums, no Medicare Part B premiums. That's included in the funding proposal. And there'd be no copays, no deductibles, no 20% cost sharing on hospital visits, and full drug coverage at no cost. Now, presumably some people would say, I would rather spend more money and get less. Okay, fine, that would actually save the state money, so whatever. But I think the vast majority of people now on Medicare would join into this, and that would bring the monies into the state. Medicaid would be easier to integrate because it's a state plan already. So you just change the rules. The only condition for changing the rules on Medicaid is states cannot make Medicaid worse. Under Trump, they do. But we would be making Medicaid better because every Medicaid provider would be paid the same as non-Medicaid providers, so it would be easier to access. I could go on more about the funding, yeah.
But Medicaid coverage is much better than Medicare coverage.
Yes.
So, and it would be wonderful if Medicare for All in Massachusetts adopted the standards for coverage of people of patients that Medicaid has.
Yes, the problem, Medicaid is, it has much better benefits on paper. The problem with Medicaid is, and it's not as bad in Massachusetts as in many states, but the rates paid are a lot lower, so it's often hard for people to have access. A lot of doctors don't take Medicaid. But yes, you're absolutely right. I mean, Medicaid is so-called wall-to-wall coverage. You get everything. Whereas Medicare has lots of restrictions and cost sharing. So the benefit package would be more like what it actually is, Medicaid. Everything would be covered. The actuarial value of the plan that we're talking about for Massachusetts would be about 96%. Everything would be covered except Band-Aids, aspirin, and some voluntary, cosmetic surgery and things like that. But basically, everything that you do would be covered. Yeah.
I'm wondering if calling it Medicare for All is misleading, because Medicare does involve your secondary insurance with insurance companies. That's where the problem is. Is it strategically wise to keep calling it Medicare for All? Or should it be universal health care or
You are
sort
absolutely
of thing?
right. It's a real problem. People used to talk about, and still do, single payer. Single payer is kind of like, what on earth are you talking about? And it's confusing, it's not familiar. So then people started talking about Medicare for all. And then it's like, okay, then improved Medicare for all. But that starts getting too long. So I welcome a better phrase. I just signed a contract to write a book about this. And one of the items in the publisher note, they send out to referees and things like that. And the publisher was like, look, we need a better title. The case for Medicare for all is like, well, do you really want to be calling it Medicare for all, given what you just said? And they said, well, maybe universal coverage. But universal coverage can be achieved in several different ways. So I don't know if that's the right thing. Single payer definitely isn't, because that's too weird and technique and wonky and confusing. So I welcome better titles.
Massachusetts has probably the biggest single healthcare industry, and I'm talking about both insurance and hospitals, of just about any state in the country. Mm-hmm. How are you going to overcome that, especially given that most of the legislature is in their pockets?
Well, that's a real, you're absolutely right. If it's not the biggest, Maryland, New York also have very big ones. New Jersey has a big insurance industry. It's one of the biggest. One of the odd things about the state campaigns for single payer is the state campaigns are strongest in the states that have the biggest healthcare industries. And one reason for that may be that these tend to be blue states, because if you have a lot of healthcare people, you've got a lot of educated people, and they tend to be Democratic these days. But that also means that a lot of these people are donating to Democrats. I had this student last year, had a file, opposition research, basically. And she was coding the campaign contributions of the top executives in the health insurance industry and hospitals, et cetera. And they don't give to, they do give to Republicans, but they give more to Democrats. And in Massachusetts, they give mostly to Democrats. They give to nice Democrats. Democrats I like. People like Joe Kennedy and, well, Mike Capuano, who, he lost his reelection. Okay, yeah, so he's on the way out. But, they give to good people. So that makes it a little harder. Also, you go to the top foundations doing research on healthcare policy. Place like the Kaiser Family Foundation, the Commonwealth Fund. They do great research, good people. The Robert Wood Johnson Foundation. Well, the Robert Wood Johnson Foundation is a branch of Johnson & Johnson. Yeah. The Commonwealth Fund, the head of it, David Blumenthal, a great guy, a good scholar. David Blumenthal is also the chief technology officer, or was the chief technology officer at Partners, where I don't know how much he was paid, but it was a lot of money. You get these people, and somebody once said, it's very hard to convince anyone of a truth that goes against their financial interest. So this is not going to be easy. It's why we haven't done it after 40 years, even though the country as a whole would save hundreds of billions of dollars and tens of thousands of lives a year. You look at the fight for the Affordable Care Act, which didn't even cut into the profits of the health insurance industry or the drug companies in any meaningful way. You know, so this is the only way this is going to happen is if, like the abolitionist movement and like the struggle for independence, it's from the ground up. You know, virtually none of the big merchants, industrialists in the United States or the colonies before supported these movements. They were from the ground up. They were people just sick and tired of being sick and tired. You know, the Civil Rights Campaign also. I mean, it eventually did get some support from big business, but I was up against all the political power in the South, the economic power in the South, and Democrats and Republicans in Washington, including Franklin Roosevelt, were like, I can't take on segregation. I'm not going to fight about this. Eleanor can do what she wants, but I'm not doing it. You know, I mean, he was very clear about that. You know, like whatever my sympathies are, I need the South for my reelection, so I'm not going to. And that's the way it is with most Massachusetts Democrats. But things are changing. I mean, there is this huge surge of interest that you people are a part of in doing a different politics. That's what the Sanders campaign gave us 2 years ago. People realized that there is a lot of interest, that you're not alone, that there are other people who feel this way, and the rise in interest in single payer, Medicare for all, improved Medicare for all, you know, that has come out of the Sanders campaign. And in a way, Trump is a gift. It's hard to say that. But he is so, so awful. And I liked Hillary Clinton. I still admire her. I donated to her campaign. You know, I cried when she lost, not just because of the guy who won, but also because I think she would have been a very good president in a lot of ways. But the fact is that the establishment Democrats showed their bankruptcy 2 years ago. And that, I think that's part of why even people like Mike Capuano, who's a really good guy, lost, because there's just, people are tired of the same old people and pushing the same old policies and not succeeding. So this upsurge of interest is what's going to do it, eventually.
Yes.
Come down to the basic question that everybody, at least is foremost in my mind. Who pays for this? I'm on Medicare, you know, some taken out of the Social Security, and of course I have supplemental, which is almost essential, even though you have Medicare. So if it's single payer or Medicare for all, or when it comes down to it, you send your doctors or healthcare providers send their bills to the government, some department. Where does that money come from? Are there extra taxes, or tell me about that.
Okay, well, the first thing to keep in mind is that we are almost, with existing government spending, what's already being spent on Medicare, Medicaid, and other programs is about 60% of our current spending on healthcare. So we're already paying as much from the public sector for healthcare as, or almost as much as Canada, a lot more than Britain and other countries are paying for total. So we're already spending a lot of money through the public sector, even without additional taxes. Yes, there are additional taxes needed to fund a state Medicare plan or a national Medicare plan, though they're not as much as you might expect. The bill that's in the State House would have an 8.5% payroll tax. There are exemptions for low-income people, for low-salary people, et cetera. This is less than most employers and employees are paying now for health insurance. The reason we could fund this with less taxes than people are spending now in what I like to call private taxes, because the health insurance that I have now is something I have to have. That makes it a tax. It's just that it goes through the Commonwealth to, I think, Aetna, that runs the state health Unicare plan. But it's a tax because it's something you have to pay, but it's collected in effect by a private agency. Now, those private taxes fund some health care and administration, marketing, profits, inflated salaries, and inflated profits. Not just normal profits, but the inflated profits of the drug companies and many of our hospitals. Take out all that waste, and what you're left with is a much smaller number that allows us to have new taxes that are a lot less than the private taxes that we're paying now. Now, if you're a senior, you just make out like a bandit here, because there'd be no Medicare Part B premiums, there'd be no wraparound insurance, you'd have full coverage, and you won't be paying the payroll tax. So you're fine. But what are you going to do? You're not going to put a big tax on seniors. So, even working people who will be carrying the burden would be making out better than they're doing now.
We have a question here, then we'll come over to you.
Okay, I have one comment and one question. So one comment on, you talked about the healthcare industry being, that would put a lot of money against it. But then I think if you take a step back, they ought to be able to be convinced to be on the side, because all of that healthcare industry is also paying all of that healthcare cost for all of their employees. Yeah. So anybody that's got a lot of employees, they have that same large percentage to get decreased. Mm-hmm. And so at the end, they could come out pretty much the same. I mean, I don't know what those numbers look like. But the only people who really lose are the greedy SOB insurance companies. Mm-hmm. So, but it seems like the Medicare industry and medical industry should, every one of those businesses have the same concerns that every one of the businesses on the film had. So that seems like that should be workable. Then back to the taxation and how the plan is paid for. So you were talking about a payroll tax on employees or employers?
Well, technically, the bill is written that the employer is responsible for 3/4 of it, and the employee for 1/4 of it, which would be 2%.
And does that give family coverage? How are children covered?
Oh,
How about people who aren't working?
Everybody would be covered.
Okay, so even though employees pay a part of it as citizens, working citizens, not that they're paying that to cover themselves.
Exactly.
Gotcha.
Exactly. The medical industry, if you go to doctors, not talking about the CEOs at the hospitals, but you go to the doctors, they are so sick of dealing with the insurance industry. And it's not just the financial cost to them. For a lot of them, it's the humiliation of having somebody, basically an insurance company practicing medicine, telling you which drugs to prescribe. So I think that there would be also a lot of smaller, the giant hospitals, Johns Hopkins, whatever, are, they're able to charge a lot. Yale Memorial, Mass General. But you go to Holyoke Hospital, they have a lot of people on Medicaid, they have some free care. They have a very different interest, and they're not earning monopoly profits the way Mass General is.
Hi, thank you. So a comment and a question. So the comment is, one thing that's just spectacular about the coverage is it covers long-term health care. And long-term health care is a frightening hole, gaping hole for most seniors, because of course Medicare doesn't cover it, Medicaid does, the impoverishment. I mean, I don't hear that much talk about the fact that that would be covered under this Medicare for All. Is that not correct? I hope.
You are right, and
yes.
it's not only the seniors.
Yes,
It's
and it's for all
middle-aged
the
people
many.
with parents or kids with grandparents,
Yes.
who worry about my mother-in-law.
Yes, so the adult son and daughter who are facing terribly damaging costs for particularly a person with Alzheimer's that are going to spend a good chance, or Parkinson's, many years in a nursing home, and if you haven't prepared, and you cannot prepare anymore because they've rigged the system, so that looked back 5 years, nobody can prepare. The elder care lawyers now do not talk about estate planning. They talk about, that it's a disaster, and they're going out of business. So at any rate, that's my comment. My question is, so what does happen? We're all probably progressives in here. We care about people and being employed. What does happen to those thousands, maybe millions, I don't know, thousands of employees, mid-level, probably not getting paid that much, in the hospital? We go there. Every time we go in the hospital, we see 15, mostly women, at these desks doing this insurance, the multiple insurances. Really and truly, what's our plan? And if we don't talk about that, I think we're missing the other side.
Oh, you're absolutely right.
We need retraining. What do we need? We need to we need subsidies for a while. I mean, it's really, not just forget the CEOs. I don't care what happens to them. I don't care if they go to hell, excuse me. But there are mid-level employees, and this is all they have and all they know. They don't necessarily have a college education, and they will be, out of luck. And we don't talk about, I've been working on See and Compare since the 1990s, and, with Archie Markham and the whole group, and here we are.
Well,
but why don't we ever talk about that?
Yes, we should talk about it more because it is one of the three most common questions that comes up. One of them is taxes, one of them is long-term care, one of them is what happens to jobs. And you are talking nationwide, I estimate over 2 million displaced workers from the billing and insurance-related activities and the insurance companies. HR 676, the single-payer bill in Washington, and also the bill in Massachusetts, provides for 2 years of unemployment insurance and retraining, which provides, a certain cushion and opportunities for retraining. One thing to keep in mind in the numbers here is that there would be a 10% or more increase in demand for medical services because of single payer. You're covering the uninsured, who would be using a lot more, and you're doing away with copays and deductibles, so you get a utilization bump from that. So hospitals and provider offices will need more staff. And fortunately, they have the staff right there because they're filled with billing and insurance-related people, including nurses who spend their time, instead of treating patients, spend their time dealing with the insurance companies. They won't be doing that anymore. They're right there. They will help. So instead of being laid off, they would move into helping patients. Many of the billing people who sit in front of the computers doing, printing out those, Mass General, like many hospitals in the United States, has more people doing billing than they have hospital beds. The first time I pointed that out, I then added, what on earth do they do all day? And somebody said, have you ever seen a hospital bill? It goes on and on and on. Well, some of those people will take the unemployment and go. Others, there'll be need for more people doing scheduling. Everything that you do in providing care for patients will go up by about 10%. So that will suck up immediately a lot of those people will have jobs within places where they are. The CEOs, the hospital CEOs will still have jobs. They're still going to need somebody to run the hospitals. They just probably will have to take a big pay cut.
So I think I have two comments and a question. One thing we have to also think about is that cities and towns are spending huge amounts of money on healthcare for their previous employees who are retired. Imagine what they could be spending that money on if we had single payer, i.e. education. And so when we think about how can we convince people about this, that's a really strong argument, in my opinion. Also, I think it's important when people say, oh no, you're going to levy another tax on me and I'm going to have to, this is going to cost me more. You also have to think about not only will you not be paying your insurance premiums, you won't be paying your deductibles, you probably won't be paying for your medications. There's a whole bunch of, if you think about all the money you spend on health-related costs, it won't come near to that. So I think it's really important in convincing other people that we have sort of these sound bites that make a lot of sense.
You're absolutely right. State and local governments would be among the biggest beneficiaries here, and single-payer advocates really need to be going to talk to the mayors, selectmen, and school boards. The reason is not that public employees have better insurance, but they're much more likely to take up the insurance and they're much more likely to cover their families. As a result, the average school district in Massachusetts and the average town's paying like 25% of payroll for health insurance. If you bring that down to 8%, then you're saving a big chunk of payroll. That money is then available for more teachers, art teachers, music teachers, or my favorite use, fixing the bridge over the Hop Brook in Amherst on Station Road. It takes like 10 or 15 extra minutes to get to Northampton from Amherst now because of that broken bridge. So they could fix that. And your other question?
My question is,
was, yeah.
as activists for single payer, I just recently heard that single payer almost passed in New York State, except the governor wouldn't sign it. What can we learn from some of these states like Vermont and New York, who have come, Hawaii, who have come close, but it's being killed?
Vermont came the closest because the legislature actually passed a bill instructing this new Green Mountain Care Board to draft a single-payer plan. They did draft the plan, and they proposed they could fund a single-payer plan in Vermont with an 11.5% payroll tax, more than Massachusetts because Vermont is a poorer state, and I could go in details about how those things work. But the governor was then shocked at the 11.5% and said, oh, we can't do it, and he pulled the plan. Now, the 11.5% is exactly what the legislature was told when they went into this process. The problem is most people don't realize how much they're spending on health insurance, and that's lesson number one from the failure we've had. Most people don't realize how much they're paying for health insurance. I could ask all of you, and if you're like my colleagues, none of you would have the right answer. After Vermont, I went around my colleagues, PhDs in economics, professors. Nobody knew. And it gets worse. Some of them actually said that they gave me a number that was pretty close to the employee contribution, which is a quarter of our full premium. The full premium is actually now on your W-2. And for me, with a family plan, it's about $28,000. With the 11.5% payroll tax, I earn like $130,000. You could look it up what I get paid. It's public information. It's about, so that would be like $14,000. I would be saving $14,000 or so at the 11.5%. And if you believe my numbers, I've got a pretty graph that shows how much everybody would be saving in Massachusetts at different income levels. You have to go up to like $200,000 a year before people would be paying as much in taxes as they're spending now on health insurance. $250,000. Of course, it will vary by family size. So lesson number one is people have to think about, have to be informed about how much we're paying already. Second, lesson number two, New York, it passed the lower house, failed in the Senate. The same, very similar in California. It's easy for Democrats to vote for single payer as long as they know somebody else is going to kill it. Because then the hospital executives and all those don't come after you. You know, it's like it's an easy vote. Jerry Brown in California was all for single payer until he became governor, and the legislature was actually going to pass it. And then he kind of leaned on his pals, and they made sure to kill it in the Senate or in the Assembly. New York, Governor Cuomo says he'll sign it, but the Senate has to pass it. And the Senate's like, well, we don't want to bother passing it because the governor's going to veto it. You know, so it's like that old Thomas Nast cartoon, Who Stole the People's Money? Everybody's in a circle pointing, that guy over there. You know, who killed single payer? That guy over there. Yeah. But we got to hold their feet to the fire is what it amounts to.
So I think we have time for one more question right here, and then we're going to have to wrap up. So we have time to talk about where we go from here.
My question is, why aren't we seeing, with the exception of insurance and healthcare, why aren't we seeing employers rising up and demanding this?
That's a very good question, and I think about that a lot. You think of all the money they'd save, and in places like Canada, I mean, you know, we know the auto industry has been leaving the United States, and people say, oh, it's because they're going to cheap labor in Mexico, whatever. That doesn't explain why they've been moving to Canada. You know, a lot of employers know they'd save money. I think one answer is there's a myth that people adopted employer-provided health insurance because of the IRS. They didn't. It antedates the IRS. Employers adopted health insurance, employer-provided health insurance, as a way of controlling their workers, reducing quits, et cetera. So big companies think, well, we've got these people. They have to stay on the job. We can get them to work harder, we can threaten them, et cetera. So I think that's one part of it. They would lose leverage over their workers. The second part is American business has changed over the last 70 years. 70 years ago, you went to work as a manager, an executive at a company, Kodak, US Steel, and you just rose within that company. Nowadays, top management goes from company to company. They're much more fluid, and they're much more involved in financial activities. So they're much more integrated with the insurance companies. Their friends are in the insurance companies. They're hoping to get jobs in the insurance companies. Most of these insurance CEOs didn't start out in insurance. They start out someplace else. So I think there's a common ideology among American business now. But the short answer is, I don't know why. You're coming up?
Yep.
Okay. Thank you.
Thank you, Jerry. It's such a complicated thing, the single payer, and so you have such a great way of demystifying it for everybody. So thank you very much. So now we need to get to work, and I think you said, Dr. Friedman said earlier on, that this is not going to come from the top, that we're only going to have a single-payer system if we have a strong grassroots movement that demands single payer. And I'm going to give you something that you can all do right now. When you show up at the polls on November 6th, as I'm sure you're all planning to do, we have the opportunity to make a difference by going to the polls and voting yes on question 4. How many of you know what question 4 is? Okay, most people don't. Question 4 is a non-binding ballot question, ballot resolution, and it's very short. I'm going to read it to you. Shall the representative from this district be instructed to vote for legislation to create a single-payer system of universal health care that would provide all Massachusetts residents with comprehensive health care coverage, including the freedom to choose doctors and other health professionals, facilities, and services, and that would eliminate the role of insurance companies in health care by creating a publicly administered insurance trust fund. So 6 Western Massachusetts districts have this question on the ballot. We have this question on the ballot. So you have the opportunity to say, yes, I want to instruct my representatives to pass single-payer health care in Massachusetts. We want to send a clear message to our legislators, and we've got new legislators, and one of them is in the room with us. Could you stand up? Dan Carey, our new state representative. And I know that Dan is a supporter of single payer, so thank you for coming today, and we wish you the best. And Dan is going to be joined by people like Joe Comerford, who is the senator taking Stan Rosenberg's place. Unfortunately, our senator needs a lot more convincing, I think, Senator Humison. But, and Lindsay Sabadosa, who is the representative from the Northampton area, who's taking the late Peter Kokot's place, is also a supporter. So we want these people to know, we want Dan to know that you have a lot of support and that we're going to watch your back. And we are going to make sure that by voting yes, if we can have a strong yes vote in these districts, that is a message to our legislators. The message is, and this is what the message is, get this bill out of committee. We have had a single-payer bill on the ballot every year for like at least the last 20 years. How many, Jerry, do you know how many years it's been on the ballot? It's over 20 years, I think. And it's never gotten out of committee. So when people say to me, yes, but, how can I afford it? Yes, but, this question and that question. What we need to do is get the bill out of the committee on the floor for debate and have our questions answered and have changes made. So if each of you gets 10 of your friends, family members, or colleagues to vote yes on question 4 on November 6th, we will be well on our way. The other thing you can do is join the Easthampton Hub of Western Mass Medicare for All. We're not so small anymore. We're a pretty mighty group, and I'd like everybody who worked on this event today to stand up as part of Easthampton Medicare for All. So don't believe the naysayers, and the naysayers are there. When we had our first meeting a year ago in September of 2017, what I said to our group is, we're in this for the long haul. It's not gonna, we're not gonna have Medicare for all next year. But I really believe we can have it. And I believe Massachusetts is the perfect place to have it. So I hope some of you will join us. If you haven't signed up on the email sign-in sheet, please sign up so we can let you know when our meetings are. And even if you don't come to our meetings, please come to our events or support us in any way you can, which reminds me that we have 2 donations jars on the back table to help just offset the cost of our printing and all those things. So if you could spare a little change, that would be great. And I also want to thank the people at Easthampton Senior Center, particularly Ed Keller, who has joined our team of the Easthampton Hub. And where is Ed?
Here.
Oh, stand up so we can give you an applause for giving us this space and being so helpful. And I also want to thank Easthampton Media for taping this so that you can tell your friends. They can watch what happened today on television. We'll let you know when. And also, Fix-It is online. So if you just Google Fix-It Healthcare, you can get the link to it and have other, we want people to watch it. It's easy to understand, and it's a good film. There's a longer version, which we didn't show, but the short 40-minute version, it really makes the case, I think, for single-payer care. So I want to thank everybody for coming today, and please help yourself. I see there's more popcorn and more cider, so help yourself to that, and help yourself to the literature on the back table. There's Medicare for All buttons for those who came in early. We got those a little bit later. So take a button and talk this up. Talk about it wherever you are. Thank you.